Hi everybody, this is Professor Wells, and this week we're going to go over Chapter 9, which is covering dental ceramics. So what are dental ceramics? Ceramic materials are highly aesthetic materials, but they're also prone to fracture because they're brittle and weak when used in the high-functioning areas of the mouth. Dental ceramic restorations can be created only in a laboratory. Over the past 3 decades, these materials have increased in strength and have been used widely. They're classified based on composition, processing method, fusing temperature, microstructure, translucency, fracture resistance, and abrasiveness. But for teaching purposes, we're just going to break them down into 2 broad categories, which are glass-based and non-glass-based. Glass-based ceramics have silica as a main component, and they have a glassy matrix. These include feldspathic, lucite reinforced, and lithium disilicate ceramics. Non-glass-based ceramics are composed of simple or complex oxides. Sorry, I have my cats in the background if you're wondering what that noise is. But the non-glass-based ceramics are composed of simple or complex oxides with no glassy matrix. Examples being alumina and zirconia. Usually, the more aesthetic a ceramic is, the more glass is in it. Filler particles are added to color the glass and modify its opacity. Ceramics with higher strength are usually of the polycrystalline type. Stronger ceramics often are used as a core, which aesthetic porcelains are placed to achieve the desired color of translucency. The primary advantage of ceramic restorations is their aesthetics. Other advantages include their biocompatibility, wear resistance under function, stain resistance, and the ability to precisely place contacts and contours of the restoration. Some disadvantages of ceramic restorations include their brittleness, their wear of the opposing enamel or restorations, difficulty or inability to repair them in the mouth, the need for 2 appointments, and also the difficulty of polishing them in the mouth. Porcelain is a term used in dentistry to describe the class of tooth-colored dental materials that are composed of feldspar, silica, or quartz, and kaolin, and are glass-like. Since they are high in glass content, they are very aesthetic because their optical properties mimic the enamel and dentin, but they're also more prone to fracture. Feldspathic porcelain is manufactured from fine crystalline powders of alumina, feldspar, and silica oxide mixed with a flux of sodium or lithium carbonate. As the powder is heated, the porcelain particles fuse together, and this is called sintering. It is used frequently for veneers. Alumina porcelain was developed in 1965 to enhance the fracture resistance compared with the conventional feldspathic porcelain. It's about half aluminum oxide by weight in a melted glass matrix. It's fabricated by dry pressing it on a refractory die and then sintering it at a high temperature. Lucite reinforced ceramics are materials reinforced with lucite crystals or lithium oxide. This mixture has more than tripled their fracture resistance. Lucite reinforced ceramics work well for inlays, onlays, thicker veneers, and anterior crowns if they are bonded. Lithium disilicate ceramic is composed of quartz, lithium dioxide, alumina, phosphor oxide, potassium oxide, and small amounts of their components. The resulting glass ceramic has a high strength, good marginal integrity, and biocompatibility, and can be used in both anterior and posterior parts of the mouth. Reinforcing porcelain with lucite crystals or lithium oxides has more than tripled their fracture resistance. So you want to make sure that the material being used in the mouth, like for instance, a crown on tooth number 30, which is in the posterior, that takes a lot of pressure from chewing, biting. Oftentimes you can see older porcelain fused to metal crowns on a patient, and you can see the porcelain has completely wore off, and you can see the metal through it. That just shows how heavy a person's bite can be, and especially over years of being in the mouth, you can also see the wear on the opposing tooth as well. Non-glass-based ceramics are crystalline-based with no glass matrix and are composed of oxides of alumina and zirconia with minor amounts of other components to improve their properties. Alumina was developed as an alternative to the porcelain fused to metal, otherwise known as a PFM. You'll hear that pretty often. It's an alternative to the porcelain fused to metal crown. It has a crystalline matrix composed of alumina and an alumina magnesia or alumina zirconia mixture called a spinel. Zirconia ceramics are the strongest ceramic materials currently used in dentistry. They have the highest flexural strength and fracture toughness, at least twice as strong as the alumina-based ceramics. They can be heat processed or machined. They can be used in the anterior and posterior for crowns or as cores for 3-unit bridges. Excuse me. Zirconia crowns can be cemented either by resin cement or conventional cements, and they are not etched or silanated before cementation. They don't respond to acid etchants like glass-based ceramics, and attempts at high etching might produce a powdery residue on the interior of the crown that is difficult to remove. Manufacturers have developed primers for preparing the interior of the crown for cementation. Zirconia is a much more opaque ceramic than lithium disilicate ceramic. To achieve better aesthetics, a layer of veneering porcelain can be added to the zirconium core. If fracturing occurs, it's usually caused by a fracture of the porcelain veneer or separation in the porcelain from the zirconia. Zirconia has only been out for a couple years now. This is the most aesthetic of all restorations, the most strongest as well. With that being said, there are times where you can go to seat that zirconia crown, and when the patient bites down, it can break. So is it an end-all cure-all? No, it's not. It does have its flaws. There is actually a video online, I'll try to find it to post for you guys, of them trying to prove how strong the zirconia crown is, and it's of a big truck running over the crown on the street. It's pretty funny. I'll try to find it for you guys. But that's just them trying to show to people that aren't in the dental field exactly how strong this material is. Ceramic materials are stiff and brittle, and these properties contributed to the fracture of weak feldspathic porcelains in early clinical applications. Even though ceramic materials are generally stronger when compressed forces are applied, it's their flexural strength that is more important for resisting fracture. Glass-based ceramics have a relatively low flexural strength. Lithium disilicates have the highest flexural strength of these glass-based materials. As for the non-glass-based ceramic materials, zirconia has the highest flexural strength of the crystalline materials and also has the highest fracture toughness. On page 133 in your book on table 1-9, this shows a comparison of the material strengths. I'd be sure to review this. You may see this on a test. Ceramic materials act as insulators in that they do not conduct heat or cold readily like metallic restorations do. They will, however, expand or contract when subjected to temperature changes. The degree to which they expand or contract is called the coefficient of thermal expansion. You will also hear this phrase a lot. It's important to know, guys. We talked a little bit about this in chapter 2 when we talked about temperature and dimensional change. To review, the CTE is the measurement of change in volume or length in relationship to change in temperature. As a result, percolation and microleakage can occur. The higher the CTE, the more the ceramic expands or contracts. This is not critically important when a restoration is made from a single material, but when two ceramic materials are used together, such as porcelain veneer or zirconia core or a PFM crown, the two materials must have compatible CTEs or fracture can occur. Translucent materials allow light to pass through the surface and into the body of the material. Some of the light is then reflected back out. The surface of a ceramic material may reflect light as it hits it. The surface polish and the basic structure of the ceramic material influence how much light is reflected. Opaque ceramic materials do not allow light to pass through them. The light is absorbed or reflected. These are the least aesthetic and must be veneered with more translucent, glassy materials to be used for anterior restorations. Glass-based ceramic crowns have a lifelike appearance, sometimes called vitality, meaning that they appear vital or similar to natural teeth because they are fluorescent and they emit light in the visible wave spectrum when ultraviolet light hits them. They're also opalescent because they take on a bluish tinge when light reflects off of them and an orange-yellow tinge when light passes through them. Ceramic materials are considered to be among the most biocompatible of the restorative dental materials, and clinical studies have not shown an adverse tissue response to these materials. There are a variety of processing techniques used to fabricate all ceramic restorations depending on the type of ceramic being used. Sintering occurs when ceramic particles are heated to the point that they melt and fuse to adjacent particles at their borders. This is done by firing the ceramic in a vacuum needed to reduce porosity and in turn produce a stronger material. In order to achieve the desired match to the tooth color, stains and glazes are added and fired to join with the previous layer of ceramic. As processing techniques advance, sintering products are being used less in favor of heat-pressed or computer-aided machining ceramics. Computer-aided machine, that's the CAD/CAM. Slip casting is a processing technique where the ceramic powder is mixed with a water-based liquid to form a mass or slip and pressed into a porous refractory die that soaks up much of the water. This mass is then fired at a high temperature to create a porous ceramic core. This core is infiltrated with molten glass by capillary action to make a dense, strong core where porcelain can be added to develop the desired color and degree of translucency or opacity. This technique can be used with zirconia, spinel-based or alumina-based ceramic materials. Heat pressing uses the lost wax technique, similar to that used to cast gold crowns into an investment mold developed from a wax pattern that was burned out in an oven. We'll discuss the lost wax technique a little more when we get to chapter 16 with the gypsum and wax products. I believe you guys have already viewed this, but since I've had to, pretty much restructure how I do my lecture and what I'm lecturing over, yeah, you guys have already heard about this, so that will be just a little review. So porcelain can then be added by layering it onto the core to complete the color and contour, and surface stains can then be added. Various processed ceramic materials are available in blocks for use with the CAD/CAM technology. A digital impression of the tooth is taken, and software is then used to design the restoration to establish the contours, proximal and occlusal contacts, and the margins. A block of ceramic material is selected and placed into a milling machine. A computer instructs the milling device to cut the restoration. Depending on the material used, it may need heat process to complete the firing of the ceramic material. So this is something you guys may see in an office that you end up being in. The digital technology, digital scanners, like I said before, are taking over the need to take the traditional impressions. However, these machines are very, very expensive. Not many offices have them. However, they are becoming more and more affordable. They're nice because you can get such detail in the impression. Technique isn't necessarily something that is required to use these machines, but there is a learning curve to them. I will try to take a video of the one I have at one of the offices I'm in, so you guys can just see how cool this machine is and all it can do. Benefits include being able to view a three-dimensional image of the tooth preparation on the computer monitor from several different angles. The dentist can then modify the preparation is needed before processing the restoration so that potential errors can be eliminated. Also, the impression procedure is simplified because no cord packing or impression material is needed. So this is just some of the benefits of the CAD/CAM technology. Some drawbacks include the initial expense of the system, a significant learning curve, and custom staining requirements. As a hygienist, the dentist can delegate specific duties to his team members who have undergone training. The dentist may want you to take a training course geared specifically for you, and you will be capable of using the scanner to capture images of prepped and adjacent teeth along with the opposing occlusion. You'll learn how to mark the location of the margins and design the restoration, and also initiate the milling process if you have a milling machine on site. This isn't necessarily something a hygienist would do. If you know how to do this, the better, because then you become more valuable to the practice that you're in. But what the doctor may have you do is take the initial scan. I don't think they would necessarily have you design the crown. That's something that they really do. But also, it also depends on what office you're in and what the doctor allows his staff to do. So if you look on page 138, there's a very useful chart that shows you where each material should be used and what it should be used for. So make sure you review this chart. So porcelains are used for more anterior teeth. They are used to make porcelain veneers and serve well once they are bonded to the enamel and used in low stress areas. Fracture tends to occur more when the porcelain is bonded to dentin, and they are more prone to fracture when used in the posterior teeth. Veneers are thin layers of aesthetic materials that are used to improve the appearance of teeth. They are bonded to the fronts of the teeth, most often anteriors and premolars, and they can be used to lighten the color of teeth, cover stains, repair chips or other defects, lengthen worn teeth, increase the size of small teeth, close spaces, or reshape crooked teeth. They're cemented with a flowable resin material. The most commonly used restorations in fixed crowns and bridges are combinations of porcelain and metal. Low fusing porcelain is used to bond to the metal. When porcelain is applied to the metal and the two materials are heated together, the porcelain chemically fuses to those oxides on the metal, forming a durable bond. These restorations, excuse me, these restorations are strong enough to be used in the posterior. New ceramic materials have been developed that are stronger, and when used in conjunction with resin bonding to the tooth structure, have been found to be used for wider applications, including the use in the posterior region of the mouth. All ceramic crowns have a more lifelike appearance than porcelain bonded to metal crowns because they don't have an opaque layer to hide metal. All ceramic restorations have found wide acceptance because of their excellent aesthetic appearance, biocompatibility, low wear rate, and stain resistance. They can be used, sorry guys, that's my cat again. They can be used for inlays, onlays, crowns, and veneers. The major drawback of all ceramic restorations is their potential to fracture. Advances in technology over the past 3 decades have led the development of sophisticated computer-assisted Advances in technology over the past 3 decades have led to the development of sophisticated computer-assisted design and computer-assisted machining for general industry and for the dental applications. Dental offices that have these systems can prepare and deliver the restoration in the same visit. Most porcelain failures result from small cracks in the porcelain that develop when the porcelain is put under occlusal loading, and they spread over time until the porcelain gives way. Problems with the chemical bonding can also lead to failure. The oxide layer may be too thick or inadequate in quantity and quality, leading to failure at the interface of the porcelain and metal. It's very important that the CTE of the porcelain and metal be compatible. The porcelain ideally should have slightly less thermal expansion than the metal. This will keep it from cracking at the interface and reduce the chance of failure. Avoid acid etchants and acid fluorides on ceramic restorations, as these will roughen the surface of the ceramic. The porcelain surface, once it's been fused under temperature, is very hard and smooth. All of the glass-based ceramic materials should be bonded to the tooth with a resin cement. When porcelain restorations are delivered, they often must be adjusted to ensure the fit. These adjustments remove the glaze from the finish. These restorations may be returned to the lab to be reglazed before cementing. It's important for the clinician to identify the junction of the tooth and the margins of any ceramic restorations, because ultrasonic scalers, if improperly applied, can chip and craze margins of aesthetic material. This picture shows a porcelain failure with a PFM crown. The metal is exposed as is a portion of the opaque layer of the porcelain used to prevent metal from showing through the more translucent outer layers of the porcelain. So right here, obviously, the dark area is the metal. And then you can see a wider area. And this is just really what covers the metal and keeps the metal from showing. And then you see over here, this is like the more tooth-colored structure that hasn't chipped off, and that's what covers this opaque layer to make it look more natural. There are two basic principles to finishing and polishing ceramic. Following both of these principles will minimize the generation of heat and surface and subsurface damage. When trying to achieve a smooth surface, it's important to follow proper sequence processing to fine and yet finer abrasive finishing and polishing instruments. Generation of heat during adjustment, finishing, and polishing can cause damage that may progress to fracture of the restoration. So when you are polishing these, and this is more so not with your Profi handpiece and Profi paste. This is more when we're adjusting the crowns if the bite is heavy in one area, and we're talking more removal of the porcelain to make the bite come together nicely. Delivering the restoration has 4 steps. Removal of the temporary crown or bridge is first. Care must be taken when removing the temporary because some preps may include a buildup of resin and pins, and this can be pulled out. You then clean the tooth surface of the remaining temporary cement and debris with a microbrush and hard to remove pieces with the scaler only if the root has had a root canal. Can you imagine scaling a tooth that is still vital? I mean, the exposed dentin, that patient would jump through the roof. The final restoration is then tried on and the contacts checked with floss. The margins must be checked to make sure they are sealed. Any adjustments needed are done prior to cementing. The glass-based ceramic internal surface must be etched with hydrofluoric acid for 5 minutes if the lab has not already done so. Usually the lab does this for you. After etching the internal surface, the surface must be treated. Non-glass ceramics do not etch well with hydrofluoric acid. They can be sandblasted internally to provide a roughened surface. All of the glass-based ceramic materials should be bonded to the teeth with resin cement. Etching can be done to facilitate bonding to the tooth structure. Bonding them to a rigid substrate greatly enhances their resistance to fracture. Nowadays, they make a bonding liquid that is self-etching, so the need to use the acid etch when you're seating these or delivering these crowns or bridges really is obsolete. Isolation is key. You are going to hear this over and over again. Same thing with sealants. When you are delivering crowns or placing any kind of restoration in the mouth, isolation is the #1 thing you have to make sure you achieve. So isolation is key, and any contamination or bleeding should be controlled. The tooth surface is then conditioned according to the manufacturer's instructions for the bonding agent being used. A bonding agent is applied, then the cement is applied to the internal surface of the prepared crown and not directly on the tooth. After that, the crown is seated on the tooth structure. Usually the doctor will press it down. The excess cement will flow out. You can take a microbrush and wipe away that excess cement. And then depending on how that cement cures, you can use a light cure or self-cure. You just have to make sure you get that excess cement off. The average lifespan of a crown is about 10 to 15 years if it's properly maintained. That is a big one too. You'll need to explain this to most of your patients because sometimes they think that since things like this cost so much, they should last them a lifetime. This is not true. If proper care and maintenance is not achieved, these restorations can fail much sooner. Sometimes we see most often is recurrent decay under these crowns because the patient's not flossing. They're going right back to the same behavior that caused them to need this crown. Most crown teeth have root canals, and the patients don't feel pain when there is recurrent decay. This is another reason it's very important that the patient maintain their regular hygiene appointments so we can monitor anything or any changes that might happen that the patient can't determine for themselves. So the dental assistant or hygienist may be asked to assist the dentist in choosing the appropriate shade for the restorative procedure. An inappropriate shade selection will result in a mismatch to the patient's dentition. The three characteristics that must be taken into consideration are hue, which is the color of the tooth, chroma, the intensity of the color present, and the value, the amount of lightness or darkness. The lighting in which a shade is viewed is very important. Most dental offices have a combination of fluorescent and incandescent lighting. Natural light is often the preferred source, and some offices replace their light bulbs with natural light mimicking bulbs. The use of a neutral background and the best color for the patient napkin when selecting a shade is pastel blue. Have patients remove any lipstick or heavy makeup and cover any colorful clothing they have on, which the patient napkin should basically cover that for you. And you may want to have the patient napkin removed altogether because the light can reflect off of that and give the natural tooth color a different appearance. So if they have like a brightly colored shirt on, I would leave that patient napkin on. I know in some of the offices I am at, we have a window in the operatory, so we can use that natural lighting. But it's just like, you know, any other kind of lighting can give it a different view. So the shade guides are very useful in helping to determine, and sometimes, you know, you can pick a shade, hold it up against the tooth like they're doing here in this picture, and turn that overhead light off. Does it look good? Turn it back on. Does it still look good? So there's different factors that go into the lighting and picking a shade. So in summary, there's a wide variety of aesthetic materials available for restoring teeth. Patients demand high quality restorations with a close match to their existing teeth, or in some cases, they demand restorations that produce a lighter, youthful smile. Think of Simon Cowell. Look at his teeth. They are the whitest I have ever seen. They don't look real, but patients want that sometimes. The dental team has to work together and understand the properties and steps involved to contribute a successful outcome. So when it comes to aesthetic restorations, like I said, some patients want the unachievable. They want bright white, they want perfectly straight. Sometimes that can't be done, and we need to kind of bring them back down to earth. And some dentists don't care. They'll do whatever the patients want. But then there's some dentists that like, I want this to look natural. We want it to look as natural as possible. That's really the way to go, because the patient may think that they want that bright, white, perfect smile. And in reality, it's not going to look as aesthetic as they might think. So once again, if you guys have any questions over the material covered in this chapter, please feel free to reach out to me. My email is hwells14@ivytech.edu.